Hi, my name is Andy Kravetz, and we are here at the Peoria Journal Star to talk with three folks about the ongoing opioid crisis. First, we have Jamie Harwood, who is the Peoria County coroner. Next, we have Monica Hendrickson, who heads the city and the county's health department. And last, we have Katie Endress, who is the epidemiologist for the health department. Thanks all for coming.
Thank you, Andy, for asking us to be here today.
All right. What I would like to ask is, because much has been said over the years. We have heard about all this stuff. Why are opioids such a bad thing? And what I mean by that is, of course, drugs are bad. But why has this hit so hard, so fast? I mean, we have been through crack, we have been through meth, we have been through pot. I mean, we have had drugs. Why is this so bad?
I would say it's pretty much how it was introduced into the communities. When we initially thought about opioids, we think about in terms of prescription drugs. And that was really the entrance point for a lot of our relationship to opioids for the first time. We now understand the addictive nature of them, as well as the prescription issues around painkillers and other different medications. And as that addiction has happened and we've kind of exploited that, as well as drug dealers have done that and added on additional chemicals, now we're seeing what we're seeing in our community, which is high rates of mortality around our opioid issue.
I would like to talk to Katie too about that, because you deal with trends. I mean, that's sort of what an epidemiologist does. With crack and other things, people tend not to overdose as much. You can, of course, but you tend not to. What is it about heroin or OxyContin or these other drugs that makes it such a risky thing to use?
Sure. Well, the rates that we're seeing are actually highest among fentanyl, which is recently coming in to play as an additive to heroin. And heroin is a derivative of morphine, and fentanyl is about 50 to 100 times more potent than morphine. So, and users may or may not know that it's been added to the heroin. So when they're using it, the risk of them overdosing from that drug is much higher.
And that is where Jamie comes in. Your office, I have spoken to you, and we've talked over the years, last two or three, about the rise in overdoses. It's shocking. I mean, you see, at times we've seen one or two each week. At times we've seen more. I mean, it's absolutely amazing. Thoughts?
Yeah, when we talk about numbers, back in 2016 we saw 32 drug overdoses, and those were a combination: heroin, fentanyl by itself, cocaine, fentanyl, methadone, and fentanyl, and some of them were a whole poly mixture of drugs. In 2017, we saw 65 drug overdoses with those same combinations that I just described. Right now in 2017, we're seeing 1 to 2 drug overdoses a day.
You mean eight.
Sorry, 2018. Thank you, Andy. I get my years mixed up.
Well, age, old age.
Yeah, of course. So in 2018, we're seeing 1 to 2 overdoses a week right now, where people are dying. And that's on an average. So most weeks we at least see 1, if not 1 to 2.
And and that enters, and that's quite amazing. By the same thing, we don't see that many folks shot each week or whatever. The Mayor Jim Artis set up a task force, a commission in 2015, and he involved a lot of these parties. He involved you. He involved your office. You were not there yet, but you were sort of. But let's talk about that and the effort one of the things that is good, I guess, about this whole crisis is it is bringing a lot of parties together to work on it. Why don't you guys talk to me a bit about the efforts that have been undertaken to try to combat this?
So
Monica?
I'll begin. When in 2016, the Tri-County, which is Tazewell, Woodford, and Peoria, identified behavioral health as one of our health priorities, along with reproductive health, cancer, and healthy eating, active living. But specifically when behavioral health, we really looked at wanting to move the needle, so to speak, and improve the number, or decrease really, the number of deaths related to overdoses, really to address the issues around opioid and other addictive substances. And so with that, we've seen a lot of partners come across all three counties to really work on this issue, whether it is the local governments, whether it's cities or counties, the state's attorney's office, court systems, coroner, but we also have to realize that this is much more than just a municipality. This is also how our entire community organizations work. So healthcare providers, whether it's the two large hospital systems, Heartland, the federally qualified health center, Human Service Center, all of them play a role, as well as community folks. We've now at the table, bringing in school districts has always been something we've done, but now realizing that libraries are one of our leading first responders to a lot of these overdoses because of the safety of the library. So really it's changed our perspective on when we deal with an issue, who are our frontline responders and how we as a community work.
That is one thing that I want to ask you guys all about. That's one of the things that I found, because I tend to write about crime here for the paper, is that you are right. The concept of who is first on the scene now has changed. It used to be, the firefighters, the medics, the cops. Now it could be a person who works at a gas station. Jamie, what are you seeing about that change? Because I know that you've spoken at length about this.
We are seeing all walks of life. I think one of the problems that we're seeing with people with this lack of care and compassion for people dying of drug overdoses is a stigma associated with the user. And I actually just had a group of East Peoria High School students in my office today on a tour. We were talking about the typical drug user, and they were all wrong on that instinct of who they think the user is. We're seeing drug users in their 60s and 70s who are cocaine addicts that are actually taking cocaine that's been mixed with fentanyl. We're seeing people in their 20s. Our average age right now is around 43 years of age for our drug deaths. So it's not the stereotypical type of drug user that we're seeing. And not only are we seeing this age demographic, we're also seeing people overdose in the bathrooms of gas stations. We're seeing them overdose in the libraries. Actually, we had an overdose at one of the local restaurants in the seating area where someone was found dead. So they're getting their drugs and they're using them in these particularly, as Monica said, safe places, and that's where we're finding them dead.
What does the data show as to where they are from, as to who, what type of person are they? What type of demographics do these folks carry? Would you have that type of data as to the, he talked about 8 ages. Are they from the city? Are they mostly from the outlying areas? Are they men, women, old, young, white, black? What?
So the majority of the residents that experienced overdose deaths in the last year were from the 61605 zip code. There were 13 overdoses within that geographical area.
But were the people found there? I mean, were the people were found there? But are they from there? That's far as we know,
where they're from.
Okay.
I don't have the information on where the overdose actually occurred, but that's where their address was.
Okay.
And I'm sorry. In some of the cases that we're seeing when we look back, and I know I provided you some of this data, Andy. For 2018, I think 3 of those originated from a different location compared to where they died. And some of them are even coming from different communities. When I look, we're having people that are residing in Tazewell County actually purchasing and using their drug here in Peoria County. Or they're using in Tazewell County, but they die over here in Peoria County, maybe at a hospital. So they're coming from different directions.
Katie?
Sure. So the majority were males, about 55%, with the highest rates occurring in white males. However, when you look at the rates of death, the highest rates occur in black males. And so the age distribution, like Jamie said, mostly is occurring between 55 and 64.
Wow.
That's the majority of overdose. And then followed by 35 to 44, 45 to 54 age ranges.
Now, are most of those deaths, are they coming from your so-called street drugs, where you either shoot up or smoke it or do whatever, or are they coming from overuse of a prescription drug? Because the average person might not think that someone who is that old is going to go out on the street looking for a fix.
So I believe majority of them are within and again, most of our death data comes from what is provided from the coroner's office when they reach that scene of point of time. And, most of it is from not necessarily prescription. But it's a really hard tell to make because by time, and Jamie, correct me if I'm wrong, by time you do an autopsy and you run the labs on it, it pretty much has a very short lifespan, so to speak, within the system. And so to collect that data is very difficult, and that's why I applaud Jamie and his staff for being able to get to that scene and work so diligently with our first responders to be able to get that information and help us better understand, is it from a prescription side and it's a healthcare issue, or is it from, like you mentioned, the street side?
So why don't we ask him, what are you finding?
The majority of what we're finding are not from prescription drugs, although we know based on our data that 3 out of 4 of our opioid heroin users started with a prescription drug habit. And knowing that, then I think we can look back at the healthcare system and ask ourselves, how did this start? And now that we know that it exists and that we have the 75% of these people started with a prescription painkiller, how do we move forward with that data? And I think that's so important. And I'm so thankful to work with Monica and Katie, the epidemiologist, to know this information, because now that we know this information, we know that we need to move forward to start at a prescription level, and what are we prescribing people for a sprained ankle or for a tooth extraction or for a sprained wrist? Are physicians still prescribing opioids for these things, or are we using anti-inflammatory medications? And I think that's a good start with the data that we have, knowing that. What we're finding on the street level in the residences are most often a fentanyl or a heroin or a cocaine that's not from a prescription.
Really? And you mentioned the need to perhaps change how we do pain meds. Has the mayor's commission or task force, has it come in? And that would be a good forum, because he has pulled together all different walks of life when it comes to this. How are you guys going to reach out? You have got all this data here. You and Katie have got data, and you guys work on health trends. There was a meeting last week that brought together a lot of social service groups. How can we go about trying to spread the word of what we need to do, and how did the mayor's group come into play with that?
So I think it really comes back to the Tri-County Community Health Needs Assessment and Improvement Plan. This is a singular improvement plan for the entire community around health. And so the task force that that Mayor Ardis has been working on is just one component of a larger picture. When the state issued their most recent opioid plan, they looked at 3 pillars. One was prevention, one was treatment and recovery, and the other one was response. And I would say that what the mayor has been working on in terms of increasing that awareness through the reading tours and the speakers, and I know the Project Recovery as well, really falls under that education and stigma reduction in the prevention side. But, I think that's where the discussion happens, that there is other players and how they all fall under that Tri-County Community Health Needs Assessment and Improvement Plan. So while our mayor is working on a very specific portion of it, when we talk about our healthcare providers and the meeting that you mentioned, the annual meeting for the improvement plan, the healthcare community is looking at quality improvements within their own system and how often they prescribe, looking at changing it from, as they call it, the smiley face scale of pain to much more of an understanding if you're walking, you're talking, then you're really not in pain compared to that self-assessment and self-perception. We have the sheriff that's looking at bringing in a treatment facility in his own capacity at the jail. And we are also, the health department actually facilitates a Narcan advisory group, or we call it Narcan 101, where we're asking all of our first responders, because right now we've talked about overdose deaths, but before they get to that, they have to overdose. And so we're trying to get a better understanding of how many overdoses we see there before they get to Jamie's door, so to speak, and where did those land in our community and how are we responding to those. And so a lot of our key players are our EMS services such as Peoria Fire, Peoria Police, and AMT. And so I think we do have all the players. It's just also realizing that I'm a health department and we do data and we do reporting and we are very good at convening community partners. And so it's also understanding that the trust and let's just say egos need to be put aside so that I trust that what Jamie's doing in terms of his coroner response is using his subject matter experts to do that, while the hospitals as subject matter experts are doing their due diligence as well. So I think what the mayor was able to do is really start the dialogue and continues to start that dialogue. And, I think that it's all part of one larger community improvement plan.
You mentioned both of you have mentioned the concept of stigma. Why is that such a big deal, and why do we need to talk about it more? I mean, using drugs is not a good thing. I mean, there are some people who would say that we're trying to make a victim out of someone who chose to use drugs. Others would say that we have to try to do whatever we can to get the folks into some type of care. What do you guys think? Why is stigma such a big deal right now? And any one of you could jump in.
I would say it really focuses on the fact that as we have better understandings of how our minds and bodies work, we're understanding that this really is a substance abuse disorder. It is a health issue versus what I think people mention as a life choice, so to speak. And so taking that approach and understanding that it is part of a medical condition as well as someone's behavioral aspects and how it manifests really takes our understanding away from you're doing drugs, shame on you, versus okay, we have better not facilitated someone that has a tendency to have addictive natures into an addictive pathway. And so where does the responsibility as a community lie in that scenario? And so I think that's why the stigma becomes a large issue.
And that negative stigma may prevent someone from seeking help.
Katie, I was just about to ask you, so thanks. As someone who tracks data, and as someone who looks at this, is there any research looking at how fast a person gets hooked? And I ask that because the mayor's task force or group has touted the film Chasing the Dragon, which was made by the FBI and the DEA to show the perils of opioids. And the term chasing the dragon comes from someone who is trying to get back to that very first high. That first high tends to be the best one, and you want to constantly go back to that, and you're trying to get to that. Is there any data out there to say because that's one of the things that I have heard in my research here is that it's so you could get hooked super fast without even knowing that you're hooked. You could try it once, twice, and you're done. In other words, you're hooked that fast. Have you found anything like that?
Sure. I don't have any specific numbers, but I do know that both heroin and fentanyl are highly addictive substances. And yes, a person can become addicted after their first use of that substance.
And I agree with her. I want to give a shout out to Chris Schaffner from the Human Service Center, who's actually watching our broadcast right now live. And I think Chris would actually comment on our website to say, hey, Chris, I think Chris would agree. For some people, it only takes one use. Why is that? I mean, as someone who's never taken any of these drugs, I really can't fathom. I just can't get how it can be that much of a hook or that much of a draw. And for some people it is. It changes the endorphin switch in your brain. It changes the chemical component and what your drive and what your need is to fulfill that synthetic opioid that's been in your brain. Now you have to continue to feed it. It's a medical condition, like Monica said, that you just don't have control over once you have that substance in your body.
Speaking of medical, Jamie, you were a nurse for many years.
Yeah,
a long time.
That's a lot of longs, Andy.
Well, you know. But you were a nurse, and could you tell me a bit about what you've seen over time when it comes to these type of drugs? I mean, I have not done it. I don't know whether they have, but you actually can say, I was in the emergency room in 25 years back, and I could remember seeing X, Y, and Z. Now I can remember over time how it's changed. I mean, you're one of the few people, and now because of your job now, you are seeing it from a completely different and sad.
Yeah, looking back on my career, so long time ago, was 20 years ago that I started my nursing career.
Wow.
And I remember back then we had a book positioned in the emergency room. We had one, and at that time I was at Unity Point. We had a book that we kept in the emergency department of all of our frequent flyers, as we called them, and who was narcotic seeking. If we had someone arrive that wasn't in the book, we'd call across the street to OSF at the time, and if they had them in their book, then we knew we shouldn't be prescribing. But I can tell you, time and time again, we were still sending people out with prescriptions of hydrocodone, Vicodin, and medications such as that. I almost feel like at this junction, during those times over the last 20 years, we've been a part of the problem, to be honest, where we would send someone with an ankle sprain out with 60 tablets of Vicodin, and then they'd go to their doctor and they'd get a refill of another 60 tablets. It was compounded in our brains over and over again to address pain for our patients. And if we weren't managing their pain, they were giving us low satisfaction scores on the patient satisfaction level, which affected our reimbursements. So it was this perpetuating snowballed problem that's occurred over the years. So I almost feel like we've been part of the problem, to be honest, controlling and managing pain.
But I would also add to that, I mean, I'm not in the nursing field, but I think when we were talking just in the past year from our Narcan advisory group, one of the things we learned was that originally people have been using to overdose or to reverse an overdose about 2 milligrams of the medication, and now they're just assuming that 4 milligrams is a basic baseline value. So even how much we're giving to reverse a drug overdose has exponentially grown to combat these because of the potency of fentanyl and everything added to heroin.
Why do you think fentanyl just suddenly showed up out of the blue? I mean, it seems kind of, it was here, then bam, it was there.
I think you answered the question when you said that somebody wanted to get that first high. And so when you kind of slope down from there to get back to that first high, you're going to want to see what you can add to those type of drugs to make it. One of the interesting facts is that part of the state's plan, even our local plan, is under response is when someone's incarcerated and then they leave that facility or correction facility and go back into the streets, so to speak, they're at a very high risk of dying of an overdose because when they had that lag to get back to that high, they take on a lot more a lot more drugs.
Or could it be that their level of resistance went down? In other words, if you don't use for X amount of time, you might not need as much, but you are still taking the same amount, and that affects you, right? Or no?
Yeah, and I think that's absolutely true.
Mm-hmm.
All right. Looking forward, I have talked to the police and to the sheriff, and what they say is the common line: we cannot arrest our way out of this. I've talked to social service people who talk about needle exchange program. We've talked about Narcan use, and we've also talked about the need to get more beds here to have more beds. All this costs a lot of money. All this takes the will of the people who want to do it. I'm asking you three who know way more about this than I will ever know. What do we need to do here? What is the road forward? This is all of what we have done. What do we need to do? Looking forward. People now know you shouldn't take a bunch of Vicodin. People now know heroin's bad. Most people know fentanyl's out there. Most people know the cops are looking for this type of stuff. Yet we still have this issue every single day, every single week. I'm not saying that things aren't working, but I'm saying what can we do that is better, or what could we do more of, and what do we need? So I'll start on this end, and we can work our way down.
Thank you, Andy, for that.
Well, all of the strategies you mentioned are evidence-based strategies, and they target different aspects of that continuum of care, whereas needle exchange programs are an effort at harm reduction. So you're going to reduce individuals with substance abuse from getting diseases or comorbid conditions if they're using dirty needles. So by exchanging them out for clean needles, you're reducing potential harm from substance abuse. With the Narcan, you're reducing the potential overdose deaths. So by getting more Narcan into hands of family members or people who use with other individuals with substance abuse issues is going to help reduce the amount of deaths due to overdose, because a lot of times, you're right, people are using in different areas like the library, and EMS might not be the first ones to respond. So by having that in someone's hand who's close by is going to help reduce the risk of death from that overdose. And then also treatment facilities, getting patients in for long-term treatment to reduce that addiction.
I would say, going along with what Katie mentioned, it's going to be twofold. One is addressing the fact that it is a community response. All the players need to really come along, and which they have been, but I think more in a singular approach of this is a goal that we are all working towards, kind of a collective impact model about our goal is to really take this needle and move it down. So I think that's part of it. The second part of it is also understanding how health equity plays a really key part in not just only opioid addiction or heroin addiction, but a lot of other addictive and health disparities that we see in our community. So understanding the different barriers that different groups of people need to address. Whether it's if you are having a behavioral health and you're moving towards using opioids or different drugs to cope with those, what can we do in terms of an upstream issue? Is it poverty? Is it economic development? Is it access to care? All of those, I think, are also larger issues as a community we have to understand in terms of how we address health disparities through identifying health equities.
I would like to touch on one thing that you said. You said that this is the world that we live in. But why should folks care if they live in a part of town where this does not happen, if they do not know a single person who has done this, if they don't abuse drugs and none of their friends do, and they don't know a single person who does? There's a lot of folks who are not touched by this whatsoever. Or are they?
I think the question is they are.
Why?
Because when you look at the health of a community, it doesn't reside with an individual. It's based on what's called the totality of everyone in that community. And so while we might be isolated from this health issue, the larger entities that have built this and have kind of moved this crisis to the point of where it is not just related to opioids. We're looking at the same upstream factors when we look at heart disease and obesity, homicide, and other social and behavioral health issues. And so I think it would be naive to think that, while I don't know anyone directly related to the opioid issue, I do know a lot of individuals that are having health issues or those disparities that come from the same upstream starting point. And I think that's where, as a community, our approach really needs to look at, because when it comes down to it, as a community and as an individual, very little is based on your individual decisions as a health. It's really based on the community around you, social economics, your behaviors, and the environment that you live in.
Jamie?
I'm glad to hear Monica say that this is not based on what I know as an individual. I can guarantee your readers, our listeners today, that we have cocaine users, we have heroin users that live in the 61525. That's where I live, in the Dunlap zip code. We have drug users in there. Just because you don't know that particular individual doesn't mean they don't exist. And they're at just as high a risk for that addiction and for that death as the person in the 05, 04, 03 zip code. It actually breaks my heart to think that we have individuals in our community that think that this is an individual issue that doesn't affect them. I totally agree with Monica that this is a community health issue, that we as a community need to come together and work towards solution for this issue. And in my mind, when I think about how do we solve this issue, well, clearly I think we still have an awareness issue where people aren't really fully aware about what's going on. Secondly, I think we have an access issue, and access to drug treatment. And when we have access to drug treatment and we get an individual in for treatment, they need to have an individualized treatment plan specifically for them and for their addiction, and maybe even for their mental health issue that they might have. Third, we have to have funding to support the treatment centers and the treatment of the individual. And I think we lack in the funding for treatment. I think we lack in the access to treatment centers, and I think we lack in awareness.
You mentioned a lack of awareness. There is going to be an event next month, April 21st, I believe. Why don't you guys talk about that? Tell me what it is.
So my understanding, this is an event that was based from an individual that had a very much personal connection to the opioid crisis, and that her goal was to really bring together resources from across the community. Think of it as a resource fair, but really to kind of shine a light on what is available in our community and how we can, as a community, leverage it for the individual, as well as create partnerships and collaborations to help address this.
And that is known as the
Recovery Project.
Right, and that is also sponsored by the Mayor's Task Force. And for those who would like more information on that, you can go to the city of Peoria's website, and there is a link for the Mayor's Commission on heroin use. Guys, is there anything else that you guys would like to add? Going once, twice?
No, just thank you for having us.
Well, I do.
And thank you for bringing up the Recovery Project, too. It's going to be an opportunity for people to talk to other people who have been through the addiction process and that continued journey of recovery. There's going to be a ton of resources. There's going to be speakers, booth setup, Narcan training going on, a ton of things for a lot of people in our community to come together as a jointed, united front to help each other in our community go through a recovery.
Okay, Katie, you're good?
Yep. Thanks for having us.
Thanks very, very much for all of the folks who have tuned in. I'd like to say thanks to Jamie, Monica, and Katie, and that is it. We are finished. Thanks.